All right, trying to find a quieter place. So thanks everyone for joining. I'm just sort of going to talk today about transcatheter aortic valve replacement, where we are, what's going on, and what we've learned. I've never given a talk while walking. This will be a new thing. Here are my disclosure statements. Oops, hold on. Wrong talk. Here we go. There we go. All right, sorry about that. Here are my disclosure statements. I proctor a bunch of cases, and the Yale Structural Fellowship Program does get grants from both Edwards and Medtronic. So I wanted to take a look back to the beginning, sort of where we are, where we came from with TAVR, understand sort of where we are now in the low-risk studies, and then talk about sort of what we're doing at Yale, some projects that are going on here, and how exactly we are doing. So I was going to start by sort of going back to the future. And one thing I think you never forget as an attending is the first time that you are the attending and your patient doesn't make it. Certainly for us as interventional cardiologists, it's something that is in the back of our mind every time we do a high risk procedure. And so this was September 4th, 2012. I made it through July and August, but this was the first patient who I had pass away on me. This was a 87-year-old male with severe aortic stenosis. He had stage 3B lung cancer, and we had planned to do a palliative balloon aortic valvuloplasty on him prior to chemotherapy because he had come in with really refractory heart failure and hypotension and critical aortic stenosis. And so we brought him down to the cath lab. We did our balloon aortic valvuloplasty. He developed torrential aortic insufficiency afterwards. Mike Clemon was there. We took an aortogram, which really just showed that all of the blood was going from the aorta was going back into the left ventricle. He had equalization of his diastolic pressures, and sadly, he passed away on the table about 45 minutes after we did the balloon valvuloplasty. So I'm going to go from September 4th, 2012, and I'm going to fast forward a little less than 7 years to April 10th of 2019, so just about a year ago. I was actually up in the Zigo room in the OR doing a case, and Mike Clemon was down in the cath lab doing a case not too dissimilar from the one I just described. He was doing an 89-year-old female with newly diagnosed severe aortic stenosis who was transferred for us from Norwalk Hospital in the setting of syncope, hypotension, shock, and urinary sepsis with E. coli. She was, as you can see, in shock, had declining renal function, was alert and oriented only ×1 with a high BNP. And despite the fact that she had an EF of only 35%, with that function, she was able to mount a velocity across the aortic valve of over 5 and a mean gradient of almost 70 with a dimensionless index of 0.15. So, really all of these criteria meeting true critical aortic stenosis. It was clear that without some sort of intervention, she was not going to survive. And so, given all that is shown there, she clearly at the present time was not a good candidate to have a transcatheter valve, but in these patients, we often will do a balloon valvuloplasty to get them through. And so that's what we decided in her case. And so here you can appreciate on the left side, what you see is, first we can look at her EDP here. So her EDP starts out at about 30 here, if you can see the cursor. And then this tracing here is her aortic pressure tracing. So you can see her aortic systolic pressure is somewhere between about 80 and 100. Her aortic diastolic pressure is around 40 to 50. And her LV pressure is somewhere between 160 to 180 with this large gradient across her aortic valve. What we have here on the left, because I know there are a lot of new fellows who are on the call. So here's a catheter coming up from the right femoral artery and a wire that's coming up the aortic arch across the aortic valve. And here's the balloon across the aortic valve doing a valvuloplasty. This kind of balloon you don't have to rapidly pace for, and you can often get a nice result with it. It's called a nucleus balloon, dog bones and house of waste in the beginning. And so there's the valvuloplasty that we did. You can see there certainly is some movement of the balloon as it's fully inflated. And right after inflation, this is what we had. So this is really what I described in our last patient. Here we're taking have a pigtail catheter in the ascending aorta. We're injecting contrast and we're totally filling up our left ventricle here. And you can appreciate how long it takes for any contrast to make it down the descending aorta, multiple heartbeats simply for this to get down, because all of their blood is going back into your left ventricle. And again, you can appreciate here what is sort of, the hallmark of wide open aortic insufficiency. We got rid of her aortic stenosis, right? Her systolic pressures are the same in the LV and in the aorta, but our diastolic pressures have really equalized. So we have total equalization of our diastolic pressures, which is symbolic of wide open aortic insufficiency, although you didn't need those hemodynamics to see it. The picture's pretty telling there. So this was at 10:22 a.m. We had just finished our first TAVR up in the OR, and I got called down to the lab right as this was going on. And by 10, and I can't quite see what time that is, but you guys can see it on your screen, by 10:40 something, this is what we were doing. And so here you can see, here's the patient initially when we started. Here was what we got after our valvuloplasty, and here, a little over 20 minutes later, here's our transcatheter valve going into this patient. This is a SAPIEN 3 valve, so it's a transcatheter valve mounted on a balloon that we've brought up from the femoral artery. The patient was on a tremendous amount of pressors just to keep her blood pressure and in this range when she had wide open aortic insufficiency. But you can see immediately after the valve goes in, this is what our hemodynamics go back to. You can see now we have this nice separation of our diastolic pressures. Here's the aorta and here's the LV, because we now have a competent aortic valve. And also, not surprisingly, what you can see a lot is our pressure goes quite high, systolic pressure in the 200s, because we now have a new valve in and we've had all these pressors that have been on board. And so I think in this time, we often as interventional cardiologists talk about our door to balloon time, but this time it was a door to TAVR time, or a time from wide open aortic insufficiency to getting a transcatheter aortic valve in only about 26 minutes. So something that, just a few years prior to that was really an impossibility. So how did we get to this place? And I think it's safe to say that in the last decade, no area in cardiovascular medicine has changed as dramatically as has our treatment for and management for valvular heart disease. So aortic stenosis pre-2010, this is really what we had. Surgical aortic valve replacement was clearly the gold standard. Was one of the most common open heart procedures that was done in any hospital setting. But if we look at the state of aortic valve replacement in the US, even as recently as 2017, we see that as of 2017, the number of TAVR procedures actually surpassed the number of surgical aortic valve procedures for the first time. And so if we look here, this is where we were in 2014, doing about 48,000 surgeries. And between 2014 and 2017, our number of surgeries dropped a little bit. So, about whatever percentage that is, 20%, 2% drop in surgeries there, going from 48,000 to 41,000. In that same time, if we look at our transcatheter aortic valve replacement, we went from 2014 from doing about 16,000 to in 2017 doing over 42,000. Again, about 150% growth in transcatheter valves there. So what got us there? And really what got us there was just a number of robust studies, robust randomized studies, looking at the benefits of transcatheter aortic valve replacement and comparing it in randomized studies to surgical aortic valve replacement. And I want to go over some of these studies because they have been fairly pivotal studies within cardiovascular medicine. So the first studies that most are probably familiar with were the partner studies. These were studies that were published in 2010 and 2011 in the New England Journal. And this was looking at the valve that you see here, which was the SAPIEN valve. And it was comparing it either in patients who were prohibitive risk for surgery to just medical therapy, or in patients who were high risk for surgery to surgical aortic valve replacement. So back in this time, we were using just two valve sizes, 23 and 26 millimeter valves. We had extremely large sheaths, 22 and 24 French sheaths. And this was a balloon expandable valve. And again, these were the two cohorts that were done there. I want to just pause for a minute here to sort of give you some background. So this study took place between sort of mid 2007 and 2010, and they chose 40 of the top hospitals with the most experienced surgeons who were there. They actually chose the sites based off of how good they were and how their surgical teams were. And so you can imagine that you are then taking patients and you're randomizing them either to surgery, which they obviously know how to do very well at these high centers, or to this transcatheter valve procedure, which the people there have never done before. So they've never done a transcatheter valve. We're not exactly sure how to size the valve. We're not doing CTs on all of these patients. We're using 2D transthoracic echo to try to determine the size of the valve we put in, which is why we only have 23 and 26 millimeter valves to start with. We subsequently learned that transthoracic 2D echo is an awful way of measuring your aortic annulus or even your left ventricular outflow tract. It gives you, a two-dimensional view, which really doesn't accurately describe your anatomy. And you're putting in these really large sheaths, 24 French sheaths for the 26 millimeter valves. And so when we look at the results here, what we see in the inoperable cohort is that, patients who didn't have surgery, so patients who were deemed just to be too high surgical risk, and we just did medical therapy for, that within 12 months, half of those patients were alive. And I think this is just an important thing to recognize. And that is that if you have a patient and you decide that you're not going to do any interventions for them for their aortic stenosis, and they have heart failure because of it. If you say, you're too sick, you're too frail, you're too whatever, that in essence, you're telling that patient that in a year, there's a 50-50 chance of whether they'll be alive or not. And look, a lot of these patients we don't want to be treating because they're not going to be alive in a year anyways. But I think it's just an important thing when to help people understand how serious and how morbid having severe symptomatic aortic stenosis is. If the patients got a transcatheter aortic valve replacement, what you see is there was really a truly dramatic improvement in their mortality rate. Now, it didn't drop it to 0 at a year, but you had a 20% decrease in the mortality at 1 year and a 25% decrease in overall mortality at 2 years. Sort of numbers that we don't see anywhere else within cardiovascular disease. Number needed to treat, talking about 4 patients to save 1 life here. So the only things in medicine that we really get number needed to treat of 4 for are things like chemotherapy. If you actually look at why interventional cardiologists take call at night as opposed to giving patients lytics, it's to prevent bleeds, reinfarctions, or death, and the number needed to treat for that is actually 18. So we're talking about number needed to treat here. They're just dramatically less than anything we had seen previously within interventional cardiology. And this is when we looked then at the cohort A, which randomized patients to transcatheter valve versus surgical valve. And what was pretty remarkable here is that we were able to get as good a result with this first generation transcatheter valve as we were with a very established procedure in surgery. And as with all sort of new devices, new innovations, whether it's a computer or a cell phone or medical devices, when something new has come along, you're able to iterate on it quite rapidly. If it's something old that's been around for a while, hard to make changes. A lot of the changes have been made, but when you have something new, you can make a lot of changes. And so the next valve that came out that addressed some of these was the CoreValve pivotal study. Similar to the partner study, it randomized high-risk patients to either transcatheter aortic valve replacement or surgical aortic valve replacement. And in this study, for the first time, what we saw was that transcatheter aortic valve replacement was superior to surgical aortic valve replacement with regards to all-cause mortality, both at 1 and at 2 years. In addition, what we saw is that there was actually a difference in stroke. That one of the questions that had come up with the partner study is that was stroke actually higher incidence in transcatheter valve than in surgical valve? But what we subsequently have seen, and actually has been repeated in all of the studies since, is that while stroke is an important thing to look for, when you look at the numbers, transcatheter valve always has numerically fewer strokes than surgical valves. And in fact, in numerous studies, it actually has statistically significant fewer strokes. and not all of them. Some of them is just numerically better, but here, for example, it was statistically better. If we look at other endpoints, and I think it's an important one to point out, one of the downsides of transcatheter valve, especially with the self-expanding valve, is you absolutely are going to get more pacemakers. The way that the valve sits deeper into the left ventricular outflow tract, that's where your bundles run. So especially when you have a patient who has a pre-existing right bundle branch block, but even in some other patients, you are going to be experiencing a higher incidence of pacemakers. When we look at other things like bleeding, new onset of atrial fibrillation, or acute kidney injury, they were all significantly better with transcatheter valves than with surgical valves. And this was at 1 month, at 1 year, and then also at 2 years. Interestingly, when we looked at the subgroup analysis from this high-risk group of patients, what you saw was that, while all patients did better with transcatheter aortic valve replacement, the patients who really did better were actually the younger patients. They were actually females, and they were actually patients who had a normal left ventricular ejection fraction. And when we look further at that, the STS score predicts their surgical risk score. And so actually the patients who did even better with TAVR than they did with surgery were patients who had a lower surgical score. And this sort of, I think, in some ways predicted the future, but what it showed is that, transcatheter valve probably should not just be used for patients who are high risk for surgery, but it may actually do even better in patients who are lower risk for surgery. And the reason for that is that, patients who are high risk, who have multiple comorbidities, and everyone, we all know this, they come into the hospital for a hip fracture or pneumonia or a TAVR or whatever it is. All those other comorbidities play a significant role in how they're going to do. But if you have a healthy patient who comes into the hospital to have a relatively safe procedure, they're going to do very, very well with the transcatheter valve. Surgical valve simply has more inherent risks to it, more recovery to it. And so even if your STS score is low, and in fact, when your STS score is low, those are the patients who really do well with a transcatheter aortic valve replacement, even with more benefit from surgery than patients who are at higher risk. One of the reasons that patients do well and that the valves work well with these supraannular valves is that with a transcatheter valve, you actually get better hemodynamics. And so here you can see we start with a valve area of around 0.7 and a mean gradient of around 48 in these patients. And with surgical patients, we do get a better valve area. We go from 0.7 to 1.5 or 1.6, but with a transcatheter valve, we get valve areas of 1.9, and with the current generations, really valve areas of around 2. And we get mean gradients in the single digits versus gradients around 12. These differences actually we suspect may result in the transcatheter valves having a longer lifespan than the surgical aortic valves. So that then moved us into the low risk studies, which were just published, I think last year or the year before. And again, looking at the 2 valve types, the Edwards SAPIEN 3 valve this time and the Evolute valve. So this was the Evolute results here. We were one of the sites that participated in this. And what this was patients who were low risk randomized to either TAVR or surgery. And in fact, there was a subarm so that if you had coronary disease, you could have TAVR plus a PCI or surgery plus a CABG. The primary safety and efficacy endpoint was all-cause mortality or disabling stroke at 2 years. And the other secondary endpoints are outlined here, included a composite endpoint, which you see there, including major vascular complications and kidney injury, new pacemakers, moderate or severe AI, strokes, and life-threatening bleeds. When we looked at these patients, the average age was about 74, about a little over a third were female. And you can see we were talking low-risk patients here, an STS score of less than 2. Again, just showing some other things. The majority of the patients had normal ejection fractions, valve areas of around 0.8, mean gradients of around 48 millimeters of mercury. So when we looked at how patients did at 30 days, in terms of our composite endpoint, you can see overall 5.3% met it for TAVR and 10.7% for surgery. That was driven primarily by a significant difference in disabling stroke, almost twice as high for surgery, almost 3 times as much life-threatening bleeds, again, almost 3 times as many acute kidney injuries. And you can see all-cause mortality, while it did not meet statistical significance and crossed the confidence interval, numerically was half as much for these low risk patients with TAVR than it was with surgery. Significantly more atrial fibrillation. Again, the one thing I will highlight here, certainly more pacemakers with the TAVR group than with the surgical group. But if you add all these things up and you say you may get a pacemaker, but you're going to have less atrial fibrillation, less bleeding, less disabling stroke, less kidney injury, I think it's pretty clear which turns out to be more beneficial. These are looking more, again, at the clinical outcomes at 1 year, where we see disabling stroke remains statistically significant. All-cause mortality in disabling stroke just barely doesn't make it. And in fact, the other thing that we do when we do the TAVR is that we keep the patients out of the hospital from coming back in again with heart failure. So you're twice as likely to be readmitted to the hospital with heart failure within a year if you've had a surgical aortic valve replacement than if you've had a transcatheter aortic valve replacement. And so if we look at these clinical implications of death, disabling stroke, or coming back into the heart failure, coming back in with heart failure, again, what you see is about twice as likely to have one of those combined endpoints with surgery as you are with a transcatheter aortic valve replacement. The procedure takes less time. Patients stay in the hospital for about a third as long, or half to a third as long, 2.6 versus 6.2 days for surgery. And again, if we look at the valve hemodynamics, we see that, you know, with a transcatheter valve, you're simply getting better hemodynamics with the valve that's put in. And again, this is for the self-expanding evolute valve. When we look at things like patient prosthesis mismatch, again, both at 1 month and at 12 months, the incidence of patient prosthesis mismatch in the severe range is less than 2% for transcatheter valves, 4 times higher for surgical valves, and moderate similarly different there. And really, this sort of summarizes why patients do better with a transcatheter valve, and that is that they recover quicker. It's a less high-risk procedure. And so you see that, you know, patients after they've had surgery, yes, by 6 and 12 months, they're back to enjoying a good quality of life. But it takes a good 6 months to get there. And at 30 days, they simply don't have a, when you look at their Kansas City quality of life score, they simply haven't recovered the way patients who have had a transcatheter valve have. One area where transcatheter aortic valves have gotten better, and I'll get a little bit more into this later on in this talk, but we still aren't as good as surgical aortic valves is with regards to total aortic valve regurgitation. The majority of patients who have a surgical valve will have none or trace. And when we're talking about transcatheter valves, you know, the vast majority have mild none or trace, but there is about 4% of patients who had moderate aortic insufficiency afterwards. And we do know that moderate or severe aortic insufficiency is associated with worse long-term outcomes. And this is an area that we've worked on addressing since these low-risk studies came out. And I'll show you some modifications that have been made to valves to address that. So this is sort of the timelines of the valves that have been studied. Within the low-risk study, they actually used some of the first generation valves, which was the core valve. They used the Evolute R, and we also used a small percentage of patients who had the Evolute Pro valve. Today, when we're in the operating room, the only self-expanding supraannular valve that we use is the Evolute Pro. These other two, they don't even make anymore. And the reason for that is that when we started with this core valve, which was self-expanding supraannular and porcine pericardium, we then moved to the Evolute R, which had a lower delivery profile, allowed us to recapture the valve, and really had optimized radial force to try to decrease pacemakers. And then we went from the Evolute R to the Evolute Pro, where we added a pericardial wrap to improve sealing at the annulus and decrease paravalvular leak. So we did a lot of work with the Evolute Pro system here at Yale. I was the national PI for the study. And what we were looking at was, does this wrap around the valve actually decrease paravalvular leak? And here's what we saw when we compared the Evolute Pro to the Evolute R valve. We saw actually not only did we take moderate to severe paravalvular leak from about 5% down to 0, but we actually saw a decrease in incidence in our pacemakers. We saw less disabling stroke. So this valve worked really well. And here, when you look at sort of the 3 generations of valve, the core valve, the Evolute R, and the Evolute Pro, you can see this steady decrease in the number of patients that have moderate or severe paravalvular leak, as high as 10% with the first generation valve, down to about 5 to 6 with the second generation valve, and now pretty much eliminated with the current generation valve. When we looked further at the STS ACC TAVR registry, looking at the 30-day outcomes with this valve, we saw similar things. We saw the incidence of death had decreased, access site bleeding had decreased, pacemakers had decreased. And further, when we looked at the incidence of aortic regurgitation, so this is on a larger study, about 1,500 patients, again, around 8% with core valve, about 6% with Evolut R, and down to under 3% with the Evolut Pro valve. So I'm just going to talk a little bit here about the Partner 3 study that was done, which was using a balloon expandable valve in low-risk patients with severe aortic stenosis. This was run by Marty Leon and Michael Mack. It was designed very similarly to the Evolut low-risk study, in that patients were randomized to either transcatheter valve or surgical aortic valve replacement, with a primary endpoint, actually in their case, that combined all-cause mortality, stroke, or cardiovascular rehospitalization. This highlights, and we talked a little bit about how the Evolut valve has changed over time. This talks about how the Sapien valve has changed over time. This is the Sapien valve that was used in the initial Partner study, going through a 22 to 24 French sheath and only available in 2 sizes. This is the XT valve that was used in the intermediate risk Partner study. We dropped the sheath down to between 16 to 20 French and added a third valve size, a 29mm valve. And in the Partner 3 study, we actually dropped the sheath size down even further, 14 to 16 French, and added a fourth valve size, really to cover all patients. As we learned, CT sizing is the best way to size these valves, and we needed more valve sizes. We talked already about the primary endpoints for this study. And so what did they see in this study? Again, similar to what we saw with the in the Evolut low risk study, but the procedures took significantly less time. Patients were in the ICU less, patients were in the hospital less, patients went home more, and patients needed other procedures less of the time. When we looked at the primary endpoint of death, stroke, or rehospitalization, 15% of patients had one of those 3 at 1 year for surgery. And when we looked for the transcatheter aortic valve, it was 8.5%. And it was really driven by each of those things. So if we look at all-cause mortality, we can see, while not quite statistically significant, there certainly is a trend there that I think we all can agree upon. At 1 year, all-cause mortality in the surgical arm was 2.5%, and in the transcatheter arm, 1%. And you can see that really starts early here in the beginning, where you just have a higher number of patients who in the first month or so die, even though they're low risk, from their surgical aortic valve replacement, and a significantly less that happens to with regards to their transcatheter aortic valve replacement. When we look at stroke, again, we see, not only numerically, but also statistically significant differences here. And I do want to highlight that within all of these studies, since the initial Partner study, stroke has been adjudicated by neurologists. We learned early on that asking a cardiologist, or even worse, a cardiac surgeon, to adjudicate stroke was not the right way to go. And so, stroke became adjudicated by neurologists for all of these patients, getting an NIH stroke scale, etc. When we looked at death or disabling stroke, again, statistically significant here, with about 3 times as many patients having death or disabling stroke at 1 year if you had surgery, as compared to if you had a transcatheter aortic valve replacement. And here's the rehospitalization numbers. We've already talked a little bit about that. So what about subgroup analyses? And really what you can see here, regardless of age, sex, LV function, New York Heart Association, overall quality of life, all groups tended to do better with TAVR than they did with surgical aortic valve replacement. And when you looked at things like atrial fibrillation, KCCQ, strokes, death, all of them met statistical significance. So really hard to argue why in any patient whose anatomy is correct, you would be doing a surgical aortic valve replacement if their anatomy was suitable for a transcatheter aortic valve replacement and your thought was that they needed a bioprosthetic valve. I'm going to skip over these other secondary endpoints here. One little difference between the balloon expandable Sapien valve and the self-expandable Evolut valve is that this transcatheter valve, actually you don't get gradients that are quite as good as surgery, and they're significantly worse than you get with this supraannular valve. You can see with surgery, we're used to sort of gradients in that 11 to 12 range. And with the SAPIEN 3 valve, our gradients are actually a little bit higher. So there has been a little bit of concern that could these higher gradients correspond to the valves not lasting as long, and that's something that's being watched closely. Again, when we look at valve areas, when we're dealing with the SAPIEN valve, we're getting valve areas of around 1.7, similar to where we are with surgical when we were at 1.8, but a fair amount lower than the 2.2 that we expect with the supraannular self-expanding valves. When we look at paravalvular regurgitation, again, the SAPIEN 3 valve does an excellent job. Really, only 0.8% of patients and 0.6 with moderate or worse. The vast majority with none or trace or mild, although you will see that surgery certainly has more with none or trace, whereas there's more patients who have mild with the transcatheter aortic valve. So I think we can conclude from the low risk studies that in a population of patients with severe symptomatic aortic stenosis who are low risk for surgery, that TAVR compared to surgery has significantly reduced the composite risk of death, stroke, or rehospitalization in a year. There's less AFib. You stay in the hospital for a smaller amount of time, and you have a better KCCQ score at 30 days. There's less stroke and improved survival at 1 year. Surgery was certainly associated with less mild paravalvular leak, and that there are differences in the valves that exist. And we've highlighted some of these, but notably the Edwards SAPIEN valve has lower pacemaker rates that in the low risk study were no different than surgery. And the Medtronic Evolut valve has better hemodynamics. In terms of the clinical implications, I think it's safe to say that TAVR should be considered the preferred therapy in low risk patients who have appropriate anatomy. Randomized trials over the past 12 years have really shown that TAVR, regardless of the patient's surgical risk, is a very viable option. And the choice of TAVR versus surgery in aortic stenosis really should be a shared decision-making process, discussing with the physicians and the patients, given the data that's available. I will say to that extent, all patients with aortic stenosis really need to be evaluated by a heart team capable of tailoring patient-specific therapies. Sending a patient just to surgery in today's day and age really is doing a disservice to the patient. And that's why, and I think most of you had gotten the email from Arnar Gearson recently, that Yale for a while now has been having a sort of a multidisciplinary specialty clinic where all these patients are meant to be referred so we can figure out what's best for them. So I thought I would spend just the next couple of minutes showing you guys what a TAVR procedure looks like in 2020. So this is a recorded case that we did a little while ago. 16 French sheath going up, guys. So this was back when we were using a 16 French sheath. We're now down to 14 French. So this is a sheath coming up the ascending aorta here. Yep. Follow me up there, Mike, please. All the way up. You can see the patient's awake. They're getting conscious sedation. So we gave 4,000 of heparin after the small sheaths went in. Can we just give 3,000 more of heparin, please? This is us crossing the aortic valve here. So we have an AL1 catheter and a straight wire as we're doing that. Then after we've crossed the wire, we'll exchange out. This is an exchange length J wire. So here I like to make sure that the wire is nicely free there in the left ventricle and not caught up under the mitral apparatus, which we clearly are. Nice and free. Look at our baseline hemodynamic assessments next. Now, now I'm just going to bring a pigtail catheter around over that wire that's in the left ventricle here. And now you can see our gradients that we've talked about before. So we're going to our baseline hemodynamics here. Our aortic pressure is about 128 over 60, and our LV is about 182 over 20, maybe 185.
So Dan, our EDP is about 18 to 20 here to start. Here's our Evolut Pro valve. Holding it, honestly, it feels and looks exactly the same as the Evolut R. It is 2 French size larger, although that's very difficult to appreciate holding it here in your hands or when you insert it. We do have a 16 French sheath in there. We'll plan on taking the 16 French sheath out before this goes in, and we'll use the inline sheath of the valve, which is located right here. With the Evolut system, because it has the ability to recapture it, you can't see through this delivery system here, and so you have to fluoro the valve to make sure that it's been properly prepared. So that's what we'll do next here. Just come down a little bit. Nice. Let's rotate there. We're going to look for our 2 paddles right there, which we can see really nicely. It's good. There's a commissure there, which is fine. Looks good. Yep.
So here's our valvuloplasty, which you're familiar with before. You can see we rapidly pace the heart, in this case, during it. Just a very quick pacing run and inflate the balloon during that.
So I give a good amount of back tension here.
Now we're bringing the valve up here to the leg.
It's nice and perfectly smooth going in there. So we're going to come over LAO here so we can watch ourselves coming around the arch. Our implant angle is LAO, so we can actually come to our implant angle to do this. We're fully demagged here, so we'll come around the arch. Yep. Just pause there for a second. And as we come around the arch, I'm going to give some back tension on this wire. We're going to make sure it's nice and smooth coming around the arch. Show me a little higher there. There we go. That's good. Okay. Stop there. We're in our implant angle here. Our pressure is nice. You mag up one there, please. So we're aiming with this with an implant depth of about 3 to 6 millimeters. We're going to deploy really nice and slowly. Let's come across, yep. We mag up one, please. There we've come across. We'll come a little bit more caudal here.
Oh, sorry about that, guys. I did not mean to go there. Let me just catch you up here.
Yeah, we'll make sure the tank's in a good position there. There we go. Let's bring that down a little bit, Mike. No, the tank's good. Just bring the valve down a little. All right, so we're going to start it about right here.
You can see I'm turning the handle here of the valve, okay. And as I turn this marker line moves up, and the valve starts to flower.
We're going to take an angiogram. So, ready to take a picture here? Okay, go ahead and inject. All right, so it's a nice step there. So we're going to go really nice and slowly here. Andrew, can you pace here? Pacing at 110. Just a little bit of heart block as we came across the valve there. Nice and slow here. We're going to watch the pressure. All right. We take another injection there. All right. Depth looks really, really nice there. I know when the pressure drops, it's good, Mike. Okay, pressure's dropped, so we'll go a little quicker there. Past our rumble strips. Pressure should recover here. Pacer off, please. Back up a 60 if needed. So back up a 60 on that pacer. Great. Okay. We're going to assess our depth here. Go ahead and inject. Yeah, so that's really nice. Okay, I've taken back tension off the wire. We're giving a little bit of forward pressure there. We're going to slowly release here. Yep. Looks like we're fully released on both sides there. Yeah, go forward just to make sure, Mike. Good. Okay. Watch this. We're going to center up our nose cone there. We're going to watch this as we come around. I have that 14 French sheath back. We demag. 16, sorry.
Hey, John, while you're showing that, can you
recapture here? We're going to bring the nose cone back to the sheath. Push that pigtail a little forward a little bit. All right. You're walking me out, Sarkis? Yeah. So you can see there, our EDP is really right where we started. You know, maybe it's slightly less, right around 18. our aortic pressure's, 140 over 60. Nice separation of our diastolics. And our EDP is actually a little less. EDP is about 60 now. So that's really nice right there.
So we do these now mostly with transthoracic echo, so we check it before and after.
That looks great. We'll take one final angio. Go ahead and check there. That's beautiful. There's nothing there on angio.
So you can appreciate if I pause this here that, this valve certainly has a little bit of a higher valve frame. You can see here's actually the coronaries that are coming off. So, here's the level of the annulus, the coronaries come off here. So, this valve can make it a little bit more challenging, the evolute valve, to re-engage the coronaries. The sapien valve sits about this high, so it comes right to the base of the coronary. So those are some of the differences between the valves. And so I thought I would just talk in the last couple of minutes about how we pick which valve. As I mentioned, we have two different valves on the shelf. And so we tend to use the Evolute Pro valve, or now the Evolute Pro Plus valve, for small valve sizes, unless there's a significant concern for coronary obstruction. We tend to avoid the 20 and 23 millimeter sapien valve just because we get better hemodynamics with the Evolute Pro valve, which may actually result to better long-term durability of the valve. We tend to use the sapien 3 valve for larger valve sizes, unless there's a major concern about annular rupture. So if we have a lot of heavy calcification of the annulus, then we would actually tend to go with the Evolute valve. I actually need to update this talk. I say here, avoid the Evolute 34 as there's no wrap. They actually just this couple months ago came out with an Evolute Pro valve. And so in the 34 size. So we now do have that availability. And then for patients in the middle of the road, so we're talking about sort of a normal size, we look at things like the iliac tortuosity, concerns about coronary reaccess, risk of a pacer. And if those things are there, we often choose a sapien 3. Otherwise, we'll often go with the Evolute Pro. So how have we done at Yale? This is some of our data that's a little bit older. So everything lags behind by about 2 quarters. So this is looking at the end of 2018. You can see that over that year, we did just under 200 TAVRs. Last year, we did about 240 TAVRs. So the numbers continue to increase by about 10 to 20% each year. You can see that if we compare our hospital, which is here for the rolling 4 quarters, to the US registry, we still do tend to do patients who are a little bit older. You can see in the rest of the country, there's a little bit of a skew towards younger patients. And I do think we need to be doing younger patients. I've shown you the low risk data there that shows how well younger patients do. Unfortunately, there still are a number of instances where patients get referred just directly to surgery as opposed to the valve clinic. We're trying to eliminate that, but I would argue that there are a number of patients in this group here that actually should be having a transcatheter valve as opposed to a surgical valve. Again, if we look at in terms of our patients' risks, the majority of our patients are intermediate risk, some high risk patients, and we really are doing not that many low risk patients. Hopefully that's starting to change, although that takes a lot of that depends on how the patients are referred to us. If we look at how we're doing in terms of overall, patients are doing quite well. Our mortality rate unadjusted is around 1%. Major bleeding around 0.5%. You'll see it's hard to be in the 90th percentile because it's 0 across the board for the 90th percentile. But we're quite happy with where we are here with regards to our mortality or disabling bleeding. If we look at our vascular complications, I know Dr. Main is on the phone, so there certainly are times each year where we have to require our vascular experts to come out and bail us out, but it tends to actually be a fairly low frequency of that. The valves work quite well. Moderate to severe aortic regurgitation here, we're very nice 0.5%. This is an area where I think we need to improve, and it's actually an area where we need to improve across interventional cardiology, both for our PCIs as well as for our TAVRs, and that's our length of stay. We're still having patients stay in the hospital. Our median length of stay is 2 days. We're trying to cut that down closer to a day and a half or so. But that takes a lot of resources on the floor and care coordination and physical therapy. But that is, I think, one of the goals of the interventional program, both for their coronary patients, but also for our TAVR patients, is to try to decrease our length of stay, including our STEMI patients. And for the fellows there, you'll be hearing some more about some of these new sort of goals that we have with regards to patient discharge and early discharge from the hospital, because they are metrics that are being followed and graded upon. If we look at our outcomes here, this is looking at aortic regurgitation. So we actually do exceptionally well. Over 80% of our patients have no aortic regurgitation afterwards. The remainder tend to have mild. This is better than the rest of the registry. So something I'm proud of there. And I think a lot of our valve selection and choice is one of the reasons why we have those excellent results, being able to use both valves and really tailor the approach for the specific patient. Again, here's our 30-day mortality in a risk-adjusted model. And here, actually, when you risk adjust, what you see is that we tend to do pretty sick patients. So that although our 30-day mortality sits closer to the 50th percentile unrisk adjusted, when you risk adjust it, we actually sit above the 90th percentile. So another thing that we're proud about, although it does note that we tend to do a fair number of sick patients here, which certainly can be a challenge. So I'll finish there and open it up for questions. I do just want to thank, all the members of the team, because really it's a multidisciplinary team that includes heart failure and echocardiology, cardiac surgery, cardiac anesthesia, as well as the nurses and technologists. So thank you all very much for listening in, and I will stop my screen share there. And then open up for questions or types or however you'd like to do it.
Hi, Dr. Forrest. Thank you so much. Can you hear me?
Yeah, I can hear you.
All right. Thank you so much for this really informative talk. I have 2 questions for you.
Yep.
Number one, I know it is commonplace for physicians to perform balloon valvuloplasties right after TAVR implantation in order to make sure the valve is fully expanded. I also believe that these valvuloplasties post-TAVR are not technically part of the information for use. So I was just curious, at Yale, are valvuloplasties often performed post-TAVR? And if so, what size and how many inflations, and for how, what are your parameters that you guys tend to do?
Sure. So when we're doing a TAVR procedure, so we have a tendency to pre-dilate the valve the vast majority of the time. So it's only in rare instances where we don't do a valvuloplasty sort of as the first step before the transcatheter valve comes in. What we have found in doing that is that it's rare that we have to do a post-dilatation. So it's really not a valvuloplasty that you're doing if you sort of inflate a balloon afterwards. It's more post-dilating the valve to get the valve to expand better. There are some instances where we do have to do that. For example, on Monday, we did I think it was a 57-year-old gentleman who had a heavily calcified bicuspid aortic valve. And we pre-dilated, we put the valve in, but bicuspid valves, the frame can often be constrained. And so in that case, we did do a post-dilatation to fully expand the frame. And so the 2 instances that you want to post-dilate a valve in are either when you have a frame that's not fully expanded, or if you have some residual paravalvular leak. So that's leak between the valve and where it's sealing up. If you dilate there, you'll often be able to resolve that paravalvular leak. With regards to sort of what balloon size we choose to post-dilate, this is all based off of our CT scan beforehand. So what we'll do is we'll measure the minor and the major accesses of the aortic annulus. When we do a pre-dilatation, we'll use a balloon that is the same size or smaller than the minor access. And when we post-dilate, what we'll do is we'll take a balloon that is the average of the major and the minor accesses. So, this is all planned out beforehand. Our fellows make a little cheat sheet that sits on the lead shield. And so we know exactly what we're planning on doing if we need to do it.
Great. And to clarify, do you do 1 inflation for?
Yeah, so if for a balloon, we'll just do 1 inflation. Usually 1 inflation is sufficient.
Got it. For like 5 to 10 seconds, something.
Yeah, or not even, you go up, make sure it's fully expanded, and you can come back down.
Okay, great. And then my second question was, if you had the opportunity to design the next Evolut valve, what features would you hope to include, such as like complete recapturability, like elimination of parallax, et cetera?
Sure. So, it's a great question. So I think, as I tried to highlight, we have two main different valves. There's a third one that's on the market now, the Lotus valve from Boston Scientific. But there are pros and there are cons of each valve. I think the Evolut valve is really nice in that you can reposition it, you can recapture it. It has excellent hemodynamics, but its challenges are, I think, first and foremost that, you make it a little bit harder to reaccess the coronaries. If you put two of them inside of each other, so if in 10 years or 15 years, one of these valves fails and I have to put another one inside it, that'll make it almost impossible to reaccess the coronaries. And so that's a major concern that we have there that that needs to be addressed, and certainly is working on being addressed in the next generation of valves. The other challenge with it is that you have more paravalvular leaks. So that's you don't have more, you have more pacemakers, which is obviously a concern. There are some modifications to the implant technique and the depth of implant that we're doing, which is bringing that down some, but it's still a little bit higher. So that's really for the Evolut system. For the balloon expandable Sapien system, right? It's an excellent valve. You get one shot, you can't recapture it, but the truth of the matter is you rarely would need to recapture it. I think the challenges with that valve tend to come more along the hemodynamics, is that your hemodynamics, they're actually not quite as good as they are with surgery. So if you had a valve like that had, great hemodynamics, you'd be in really good shape. The other challenge with the Sapien valve is because it's balloon expandable, and patients who have really heavy calcification, you can risk rupturing the annulus as you push that calcium out to the side. So I think it's safe to say that you're probably going to have instances for each patient where you're going to want a balloon expandable or a self-expandable valve, but both of the valves have ways that they could get better. They have their strengths and they have their weaknesses.
Yeah, that makes a lot of sense. Thanks. I actually have one additional question.
Yep.
I know like MitraClip really transformed the field for mitral valve intervention. I was curious, in aortic, in the aortic world, we don't really hear as much about transcatheter repair. Do you see any like value or future potential for a repair procedure?
Yeah, so I think you can learn a lot of that from what we do for surgery, right? So if you can't repair a valve surgically, there's no way you're going to repair a valve transcatheter. And so when you have degenerative calcific aortic stenosis, that's not a valve that's repairable. And so, you're not going to end up with valve repairs for calcific aortic stenosis. Now, there's been debate back and forth about valve repairs for aortic valves in general. It is at times done for younger patients who have significant aortic insufficiency, although there's a lot of debate about the long-term benefits of that. If you look at the 5-year reintervention for aortic insufficiency that's been repaired, it's dramatically higher. It's about 4 times higher than if you've had surgical aortic valve replacement. And so, aortic valve repair is something that's actually, if anything, in the last number of years has fallen out of favor. Whereas, mitral valve repair, and I'm talking surgically here, has sort of more techniques, robotic techniques, et cetera. So I don't think that we're going to end up doing more aortic valve, transcatheter aortic valve repairs. It's the replacements that are there. What I do think is interesting is, there's other things that would be great as it relates to aortic valve disease. And if we, we have no way to prevent the disease. You have a patient who has moderate aortic stenosis who's 60 years old, they're going to develop severe aortic stenosis, and you can't stop that from happening. So are there drugs that can address that? The other thing is that these valves that we put in, they don't last anywhere near as long as the native valve that the patient was born with, right? You're born with a valve that lasts you, 75 years. You get another valve at 75, that only lasts you about 10 years. So and the reason for that is that the leaflets that are of the valve that are put in, those bioprosthetic leaflets that come from pericardium of cows or pigs, they just don't last that long. And so there's a lot of research going into trying to find different polymers, different materials that actually will last. And all you need is a material that won't thrombose and won't calcify. But it's been exceptionally hard to find that. And certainly our vascular surgical colleagues have been working for a long time to find, to find grafts and other things to stay open. We still, from CT surgery, we still use saphenous vein grafts because we simply can't find a conduit that either won't thrombose or won't calcify. But that's coming. There's a lot of work that's being done there, and I think we'll eventually get there.
Sounds great. Thank you so much.
John, can I just use these last few minutes to
Yeah, please,
plug
Steve.
the research
Yeah.
protocols? So let me just bring that up for everybody. Just a reminder, these are the ongoing cath lab research studies. Reveal IFR enrolled their first patient last week. Samid Shah's the PI, and it's looking at use of FFR, IFR compared to angiographic parameters of gradient across lesions. Women first, Elisa Alton is the PI comparing FFR in women. So anyone who has a positive stress test and may need FFR would be a candidate for this. And then I think one more slide, here we go. The Evolve registry, and then CREST-2 and CREST-H. Carlos Mena for the CREST studies and Glenn Henry for the Evolve trials. So everybody keep your ears and minds open about candidates for these. Thanks. I think that's it, unless anybody has any other questions for Dr. Forrest or myself, we'll call it a day. Thank you.